So welcome to Cake and Pie, meeting. It's such a nice name. Well, I think we can start our symposium now by, may I ask each of the speaker, I think we are come from different countries in ASEAN, right? So we may take turn to introduce ourselves and then we can start the meeting.
Well, my name is Rina from Jakarta, Indonesia.
Hi, I'm Muiz from Malaysia.
I'm Pimkwan Jaruampornpan from Thailand.
I'm Jessica Maria Abaňo from the Philippines.
Well, I think this COVID situation in Southeast Asia is kind of still going on. And I think, we have a kind of new news every day, almost every day. So I think we better start from Indonesia because I think we have a quite interesting news from Indonesia in these few days, right? About maybe you may tell us about the situation of maybe the healthcare workers who had the Sinovac injections and then they got caught with COVID-19 again, and maybe some other stuff that you want to tell us. Can you please? Thank you.
So I think maybe I'll start with the presentation. Is it okay, Dr. Paisan?
Yeah, sure.
Maybe it's not really talking about the latest news, but at least I share our experience in Indonesia first.
Yeah, that's great. Thank you.
Okay. So thank you, Dr. Paisan, for inviting me and the Indonesian Ophthalmologists Association to speak in this wonderful session. So we're talking about the pandemic impact on Asian ophthalmologists. And actually, I'm going to be talking differently from the other panelists, I guess. I will talk about also COVID-19 and the dry eye. So my name is Rina and I work in Jakarta, Indonesia. So maybe this is the first meme I distribute to all my friends and colleagues because I want to scare them. Please stay at home if you don't want your ophthalmologist treating your pneumonia. So what is actually ophthalmologist's role in this COVID-19 pandemic? Because our knowledge in ophthalmology is not exactly directly linked to COVID-19. But actually, I'm in this pandemic era, I'm more busy than ever before this pandemic era. So I will share with you what we had in the pandemic in the last couple of months. So through the Indonesian Ophthalmologists Association, or PERDAMI, we developed the guidelines. So I was lucky enough to be involved in the developing of the guidelines. And also, I also watch and witness the development of PERDAMI Young Ophthalmologists that became active nationally and internationally. And I was also clinician and researcher in 3 pioneering hospitals for COVID-19 care in Jakarta, which is Cipto Mangunkusumo Hospital, Universitas Indonesia Hospital, and Emergency Hospital in Wisma Atlet. So this is the guidelines. We can see in this link, perdami.or.id. So we developed guidelines for the ophthalmologists to face the era of the pandemic and also the new normal adaptation. I was lucky to work with many wonderful people, Prof. Ratna, Dr. Andi, Dr. Sidik, the head of PERDAMI, and also all the experts in each subspecialty in Indonesia. And the chapter's content was the PERDAMI commitment in good ophthalmology care amidst the pandemic, general and eye clinical overview, infection prevention and control guidelines, ophthalmological care guidelines and settings, including which cases that is prioritized to be taken care of, and how to face the new normal adaptation, and also telemedicine. And we talk about the most principal thing is to be smart. So this is the mnemonic in Indonesia, cerdas, which means smart. So we suggest to screen, pre-arrival screening to prevent risk of transmission. We ask the ophthalmologist to measure patients' health condition in the triage before coming or in the hospital. and assess and regulate individuals' mobility around the patient to prevent cross-infection, redesign contact area between doctor-patient as minimum as possible, and take priorities upon eye condition that need to be managed immediately or whether it can be delayed. And we ask the ophthalmologists to remember their own health too. And this is the young ophthalmologist. Actually, the young ophthalmologist chapter by Perdami was started in our national meeting in September 2019. But then it didn't become so active until maybe this is Dr. Difakan already showing himself in the Q&A chat. So he take us all in a first online conference of the Asia Pacific Young Ophthalmologists in April 2020. And now we already have our own platform in the social media, and it's becoming very active. And as for our young ophthalmologists also, the core activities flourish. We have the many core activities, including even photography and culinary and plants, arts and music, so it's really exciting. And we have newsletter which already have ISSN, so this is really the COVID-19 pandemic brings us together and more active. And the role of ophthalmologists is actually quite a lot. So maybe you remember the first whistleblower is an ophthalmologist too, and I work in 3 hospital, RSCM Kiara. It was founded in April. Initially, it was for child health services because the COVID-19 case is rising. Therefore, it is open and we have serviced a lot of patients afterwards. And the facilities, because RSCM is the National Tertiary Center, we have almost complete facilities for COVID-19 patients. And also the University Indonesia Hospital is the main hospital that have many vaccines delivered for the society. So even the President Jokowi came to our hospital and see how it's running. And also this is the first hospital that is but set up by the government, because it is actually an athlete's house. So they have already many towers, and all towers are changed into the COVID-19 patient service facility. So what are the roles in the Wisma Atlet or the athlete's house? We develop clinical pathway there for eye problems, and we have many patients starting from the light one, such as subconjunctival bleeding, and to the severe ones such as Candida endophthalmitis, cavernous sinus thrombosis. So we have a very active role in taking care of this patient. Also, we have many adverse events following immunization, as Dr. Paisan has mentioned before, and we are in a team collaborating in taking care of these. And how about the research? This is the topic that I'm also passionate about. It is the dry eye. And we're talking about that because we already know all the symptoms for COVID-19, fatigue, fever, dry cough, loss of smell, but there are already lots of publications that report there's an ocular surface manifestation in COVID-19 patients. Therefore, we would like to know how is it in eye patient? So the aim is we try to look for the SARS-CoV-19, SARS-CoV-2 from the conjunctival swab using the PCR. And we also noted the eye symptoms, the OSD keratograph, and also we look for patient funduscopy profile. This is the 3 hospital, and the design was we did the conjunctival swab sampling, the OSD data, the ocular surface disease index, and then the keratograph fundus. And on the day 7, we repeat the conjunctival swab sampling, the OSD, and on the day 14, we also repeat the conjunctival swab sampling and OSD. We try to look whether there's differences in ocular surface complaints in COVID-19 patients, and are the complaints related to objective parameters of the dry eye, and what is the prevalence of SARS-CoV-2 positivity in conjunctival swab. And this is the result. We recruit 157 patients and evaluate them with OSD. And we have 3 groups. The first group, Group A, is actually patients that is negative with COVID-19. So they came because they have close contact to a COVID-19 patient, but the result is they are negative for COVID-19. And Group B, they are negative for COVID-19, but they have history of positive COVID-19. And in Group C, these are the group who has positive COVID-19, but we divide them into C1 that have mild COVID-19 and C2 that have moderate and severe COVID-19. This is the patient demographic. I won't go through them all, but most of them have cough, fever, and sore throat. There are more female than male, and they have also occur symptoms starting from redness, itchy eye, epiphora, and swelling eye, although the number is not that high. What we found is with the OSDI pattern, in Group A, in week 1, 2, and 3, there are not so much different. Also in Group B, there's not so much different. But in Group C, where the COVID-19 was positive, we can see that most of the patients have quite bad OSDI at the beginning, but they are getting better a week after week. And then this is the keratograph result. We look at the tear meniscus height, redness, and the nick boot, or the breakup time. There are no difference between the group, but when we if we compare them with the OSDI or the subjective complaints, we found that the patient without COVID-19 disease have less subjective complaint, even though the keratograph through the nick boot and the TMH indicate they have dry eye signs. So you can see in Group A and Group B, the OSDI most of them are normal, but in Group C, where the COVID-19 is positive, they have complaints of dry eye through the OSDI questionnaire. Sorry. So this is the PCR, and this is a funny thing that we found. In the PCR, we can find that in the Group A, where the COVID-19 was negative, there are no SARS-CoV-2 found in the conjunctiva, but in Group B and C, we can find it, and most of them are in the Group C1, where the COVID-19 is actually mild. But when the COVID-19 is already severe, we cannot find the PCR from the eye. So actually, we have to be careful in the patient with COVID-19 that is mildly, when they have mild symptoms, because actually we can find SARS-CoV-2 from the conjunctiva. And this is the symptoms, the dry eye parameter in those patients that is positive with SARS-CoV-2 in the eye. And we can find that both in objective measurement and subjective measurement, they can complain about dry eye too. And then we do the whole genome sequencing of the SARS-CoV-2 from the conjunctiva. And this is one of the patient 159, and they have a CT value, low CT value for the N1 and 2 target gene. And we found the spike mutation in D614G, where it is the most dominant mutation of SARS-CoV-2 in Indonesia since March 2020. And we already published it in GSAID. And it is 10 times more infectious, but actually not more harmful than the original virus. So through our research, we conclude that actually subjective ocular surface complaints are more prevalent in severe COVID-19 manifestation. So I think we need to study further about the OSDI questionnaire to predict whether this patient will have systemic disease course that is severe than the other patients. And the PCR SARS-CoV-2 for the conjunctival swab is more prevalent in mild moderate COVID-19. So I think we need to be alert more about the chance of transmissibility through the conjunctival secretion. There is no relationship between subjective ocular surface complaints and objective parameter of dry eye. So I think research is needed further to prove the presence of inflammation of the eye using inflammatory markers in the eye that can be taken to tears and compare it with systemic inflammation. And actually we have already the fundus profile, and we plan to analyze it and do a bit AI on it, although maybe it's not as sophisticated as Dr. Paisan's, but we plan to do it next. So I think ophthalmologists, although we don't care for the lungs probably, but I think we have a lot of role in this pandemic. And thank you. I would like to thank all my colleagues in all these institutions, and I will give it back to Dr. Paisan. Maybe we can talk about other things too. Thank you.
Well, oh, thank you very much for the insightful presentation, Dr. Rina. Well, can I ask just a simple question here? So
Yes.
The genetic sequence that you perform, I mean, well, the mutation that you found in Indonesian, is that the one which is specific for Indonesian, or is the same as the other mutation?
So it's actually already known, the mutation that is already circulated in Indonesia. So it's not specific, but it is different from the original one.
So is it the mutation from India or UK, the same strains or not?
It's in Indonesia.
So it's specific for Indonesia.
I have to check, but I think it's already known. It is circulating in Indonesia.
Oh, thank you. Let us move on to the next presentation. I believe the next speaker will be Dr. Muiz from Malaysia.
Yeah, hi, thanks.
Yeah, hi, nice meeting you again.
Good to see you.
Yeah, just go on here. Thank you.
All right, let me just share my screen. Yeah. Okay. Thank you, everyone. Thank you, Prof. Paisan, for giving me the opportunity to speak here. So just a bit of background about why I'm here, actually. I'm the Vice President for the Malaysian Society of Ophthalmology in Malaysia. And we were one of those who were more or less counseled with regards to what sort of management that we are going to have with regards to our patients. And in my hospital itself, I'm with the Tun Hussein On National Eye Hospital. At the beginning of the pandemic until the end of the year, end of last year, I was the chairman for the Infection Control Committee, which oversaw how we manage all sort of infections, especially patients with COVID or COVID-related issues in our hospital. So I have to share a bit of this background because it is interlinked quite strongly. Politics and virus, actually two very dangerous parasites, yeah. But unfortunately, they share something in common in our country specifically. So in Malaysia, the first case was seen on the 25th of January in 2020, mainly by some tourists from China entering the country via Singapore. And not long after that, in February, we had some political crisis, which saw a change in government. There was some politicians who jumped over parties and things like that. So we saw a whole new government with a new prime minister, new health minister overnight. So it was a bit of messy because they were not really in the loop with regards to the national policies and things like that, which I think was already quite ready in early January, seeing that the potential for pandemic was here. So officially, the first local spread was in about March, somewhere around here. This is what we call the second wave. Following that, we had our first lockdown on the 18th of March, which lasted about 6 weeks to 2 months actually. So we call it the Movement Control Order 1.0, and in May we relaxed it. So during the first lockdown, we were very strict with regards to people movements. Everyone, we had roadblocks all over. It really looked like a war zone, to be honest with you. Cars were not allowed unless you were really, those who really were allowed to go to work were like those in the hospitals, banks. Even banks, they had selected branches open. A lot of factories were not allowed to open except for really crucial ones. In fact, for the first 1 or 2 weeks, almost the whole country was literally shut down. Even some of the key factories were not allowed to open as well. So it was quite different as well, but there were some ramifications which I will go into detail a bit later with regards to our patients, not just ophthalmology, but other fields as well. And by June, we were a bit more relaxed. We were seeing a bit more movements. So we were quite happy to see that it wasn't going up. If you look at the graph, we were just happily going with our 2-digit new cases. Unfortunately, in September 26, we had the politicians decided that they wanted to have an election, a state election, because again there was some instability in the state. So they had a state election, and when the problem with elections is that every politician and their entourage would all gather at one place to promote their parties, promote their respective candidates. So people were flying in and out of Sabah. There was no restriction of movements. People were just seeing, we were just closing. I mean, there was no distancing between each individual. So we were not surprised that the cases start to increase that time. And most of the cases were actually those who were started off from those who went to Sabah during that time. And it got worse. In January, they had another lockdown, but this was more selective for certain states which had more cases. And on January the 12th, they called for a nationwide state of emergency. It's more political because there was another, instability in the parliament, which could result in another nationwide election, a general election. So that was the reason why they had this emergency. And also at that point, we were worried that our health care was a bit more stretched. Unfortunately, and in February, late February, our national vaccination program started with all our frontliners. Our doctors started off, and we can see a bit of a dip in the. We are not too happy with the rates of the vaccination nationwide, but we did think that there was some things were looking a bit more brighter. Unfortunately, it picked up again. The cases start to pick up again, and on the 1st of June, we had another lockdown. So we are currently at the moment in another lockdown. Fortunately, we are now more mature. We know the statistics, we know the data from which industries who can go to, who should go, and with regards to who need to be staying home, and patients are more free to come to hospitals, and hospitals are open, unlike the first one, which we will go in a bit later. I will give into a bit detail a bit later. So what happened was, during the first lockdown, all hospitals and eye clinics were closed for 6 to 8 weeks. Completely no outpatient, obviously no surgeries, and this was specific to government hospitals. The private hospitals were running at very, very low numbers. One patient couldn't come. Number two, we were very selective of who to come, and we more or less took up our files, looked through the patient files, and just called those who we thought should come. However, there were no elective procedures. We decided we were not sure, because the general consensus at the time was we should keep the ICU beds ready in case of a surge, because at that time we were more or less looking at Italy as a guide of what to expect. However, when we did open the clinics, when the government hospital did open the clinics, the consultation numbers were much less. We were restricted to about 20% capacity. Patients were allowed. We really triaged patients who need to be seen, and instead of the full 5 days a week, I think they were running alternate days as well. The idea was to minimize the risk of cross infection or getting infected and things like that. Yeah, I think things were at that point. I mean, we're talking about March, April, May, June last year, when we did not really understand the disease well. So once we did start opening up the clinics, we had issues with some patients which we did need to see we were not able to contact. Some could not come because they were separated from their family in terms of districts or states where they cannot cross over to come over to hospitals. No one to take them, and a lot more who were just afraid to come to a hospital because of what they heard on about the disease, about COVID as well. And one of our major hospitals within Kuala Lumpur was converted to a pure COVID hospital. So their patients had completely could not be seen. So that's one whole block of patients which need to be transferred to other centers. So as we all know, at that point, there was no clear guidelines. We were just going on based on health declaration forms. We had issues with patients not being honest about their contacts and things like that. And we did, as a society, did create a forum for discussion. We brought in infections control, infectious disease specialists on board to have a discussion on what and how to manage our patients. And the general consensus at that time was we should not have to be too rigid because we are still learning about the disease. And so we just elected to use the ministry's guideline as because the ministry's guideline is ever evolving. It's not fixed. They keep changing, the updating based on what they know about the disease with regards to close contact, with regards to quarantine period, who are close contacts, and other details. So things like, I mean, very basic things which was a bit of issue initially was like even mask wear. During the initial periods, we had a shortage of masks. Mask was like gold, you know. When they did sell, it just finished within a few hours. And then people start using cloth masks, which was not allowed. And then things get a bit messy in the hospital when we decided that cloth masks were not safe enough to be used, and proper surgical mask was not freely available. Physical distancing was quite easy with temperature checks, easy to, and in Malaysia itself, we have our contact tracing app. So when surgery did resume, many interpretations for pre-op testing, even now, not so clear cut. But most of, with the rising of the cases, we used to do just a rapid test for LA cases and PCR for GA cases. And initially, it was quite interesting. Even there are some centers we actually admitted patients, did the test, quarantined the patients from outside world until the results came out, positive or negative. Then only they operate the patients. And the mass quarantine, sometimes we were planning for a patient to be operated. The patient came back positive. Then the surgeons who was planned to operate that patient and many others could not proceed with the operation because he is quarantined, as he was considered as a close contact. The other challenges that we had was our programs training was paused for 6 months minimum. Even now, they are not running full power with regards to the programs, masters and fellowship. There was no new intake last year. It was delayed to December. All our trainings were online, and a lot of the compulsory attachments, for example, the neuro ward attachments, the medical attachments was not possible anymore. And as we all know, there's a boom in webinars. And the latest update I heard as of last week, ophthalmology medical officers are now taking care of COVID wards as well, because we are more or less quite stretched. Our ophthal wards in the government hospital has been converted to COVID wards. So now like Dr. Rina, we are ophthal MOs are actually managing the pneumonias, yeah. And the other thing that we noticed now, probably about 6 months, 8 months down the road, was that we have a spike in half-managed cases, which are, for example, patients were diagnosed with severe non-proliferative diabetic retinopathy now show up as with vitreous hemorrhage, with full-blown PDR, and cataracts, which were now coming in with bilateral cataracts. Those dense cataracts are now hard rock cataracts, you know, and patients. Oh, I remember in April getting a call from a patient who ran out of her glaucoma drops, couldn't exit her village because the police said didn't allow her. So she's quite worried because she had one good eye, and the thing is, I've not seen her since, so I'm not sure whether she's okay or not. And things like patients' diabetes control, people had just ran out of medications at that point. But currently, now that we know a lot better how the disease spread and how to control, and with the doctors being vaccinated, we have now relaxed on the healthcare. Patients more or less can visit hospitals, except for the designated hospitals. They can go and see doctors. So the only catch is if you are under the government hospital, you are a patient in a government hospital, you now have to go to private to get treatment. So that's something. So just in current state, we're still under lockdown. We've learned a lot about from the last MCOs what we can and cannot do. Most of the healthcare, all our healthcare workers are now vaccinated, and the guidelines with regards to quarantine to the healthcare workers which have completed their vaccination are quite lenient, because we don't see so much of the cases, and we test everyone for the test, and the tests were much more available as compared to previously. In the past, those who were in the rural, we were not able to do the test because there was no testing center nearby to test them. Now most of the general practitioners are able to do the test. And the latest update as of this week, our health system is quite strained. Most of the ICU beds are filled up, and not looking too good. Just hoping that the numbers start to drop. It was dropping last thing. We were playing around 7,000, 8,000 cases per day. Now, today was 6,000, but yesterday 2 days ago was 4,000. Things were looking quite positive, but unfortunately, not at the moment. So just like to thank all our frontliners doing hard work, protecting us, and hopefully it was useful for everyone. Thank you.
So it seems that Malaysia is one of the countries that's been hit hard by the pandemic in Southeast Asia. Well, it seems that the situation looks like in India, right? You have the pandemic, which is linked with politics quite a lot. And the kind of like 6,000 cases per day is quite a lot for Indonesia, for Malaysia. So right. how many deaths per day now?
As yesterday, there were 60 deaths for the whole country. We personally, I lost a colleague, ophthalmologist to COVID. We had one of my former ophthalm nurses died for COVID while she was pregnant. They managed to save their baby, so things are a bit traumatic as well, even on our side, like from the doctors. Yeah.
Wow, that's pretty sad. Sorry for that. Well, let's move on to the next speaker, Dr. Jessica Abaňo from the Philippines. You may share experience with us from the Philippines side. Thank you.
Yes, good afternoon. I'm Jessica Maria Abaño, and I'm from the Philippines. I will be talking about ophthalmology practice in the Philippines in time of pandemic, particularly what the Philippine Academy of Ophthalmology has done. I am the chair of the Committee on COVID-19 related matters and the immediate past president of the Philippine Academy of Ophthalmology. Likewise, I had one private eye center in the Philippines. So pretty much like Malaysia, the first case in the Philippines was in January 2020. And it was from a Chinese tourist. And the first death, actually, the Philippines was the first country outside China to record a confirmed death from the disease. The first local transmission, pretty much like Malaysia also, was recorded on March 2020. And because of this, the national and the local governments have been imposing community quarantines to limit the spread of the virus. And initially, March 15, we started what we call the enhanced community quarantine that was implemented from March to May 2020. And this ECQ was the strictest of these measures. And it is effectively, like in Malaysia, a total lockdown. So no one could really go out and in the country, particularly in the central part of the Philippines, which is Luzon. So the ECQ affected roughly around 57 million people during its peak. And the challenges during this time for the ophthalmologists and of course the patients as well was initially we had very limited knowledge about COVID-19. Second, during that time, as how Malaysia has experienced it, there was limited or really no access to eye care. So that time, there was no public transport, no face-to-face consult. And what happened in Malaysia as well, some of our ophthalmologist colleagues were actually sent to the COVID wards, the ERs, and other places to treat COVID as well. So we also had, unfortunately, some of our ophthalmologists had suffered from the disease as well. Some actually was even in the ICU for so many months. And another thing was there was lack because so much need for PPEs. We had an availability of some of them, like the mask for a time. It was really, as the previous speaker said, it was like gold. Okay. And of course, the Philippine Academy responded to this. We identified the challenges and the problems during that time. Thus, we created the ad hoc committee on COVID-related matters. And the objective of the committee was to address the needs of the PAO members, the patients, and the public during the pandemic. So the ad hoc committee actually worked with the standard committees, the standing committees of the Philippine Academy of Ophthalmology, which included the Committee on Standards, particularly the Committee on Continuing Education in Ophthalmology, the Committee on Publication and Library, and of course the Committee on Public Relation and Information. Additionally, we also collaborated with the subspecialty societies of the Philippine Academy of Ophthalmology, the chapter societies, and the training institutions. So one first thing that we had to do was to make sure that the communication was good. Because there was no face-to-face, we did have a community Viber group. We updated our website. We also had a Viber group with the societies, training institutions, And I think a bit of importance is our Facebook page, actually. Why? Because you see, we have roughly around 1,781 ophthalmologists. And by doing that Facebook page, we were able to reach out to at least 1,400 of them. So that's quite important, and I will elucidate later on how it also helped in our continuing education in ophthalmology. So you can see on your left side, this is our website. We had a COVID advisory for the general public, also a COVID-19 advisory for the ophthalmologist. And to the right, we had also this community Viber group, which was able to reach out to roughly around 1,200 ophthalmologists instantaneously. So we also, the committee also provided current and relevant information regarding the disease, its treatment and prevention, and how it relates to the ophthalmologist. So you can see here, it's through the website as well as through our community Viber group. Additionally, these are, we wanted to update them on the coronavirus update for the ophthalmologists. We also had links to AAO, COVID.ph. Cornea also had infographics regarding the facts for the general ophthalmologists. And also the VRSP had infographics as well, or the Vitreoretinal Society of the Philippines, on hydroxychloroquine effects or side effects. Also, we had a list of urgent and emergent ophthalmic procedures, recommendations, etc. So during the lockdown, as there was no face-to-face consultation, we did, and we were, we wanted our members to be adept in doing teleophthalmology somehow. We did series of webinars on teleophthalmology. So initially it was telemedicine in the time of COVID, and then we also looked into the legal aspect of telemedicine. Additionally, as Malaysia has actually experienced training of our undergraduates, our interns, our residents as well, was put on hold. So we did have some webinars also on the digital innovations in academic ophthalmology during and beyond COVID. So these were the things that we provided our members. And when the lockdown was nearing its end and we were actually anticipating opening of our clinics, we did have webinars on how to keep our clinic safe. And like our Malaysian colleagues, we did collaborate with our infectious disease specialist to tell us how we can properly prepare our clinics for the coming of our patients. Additionally, we had some members who are very adept in making the clinic a safe place. So it had to do with how sure are you if your mask is safe, and how to choose the mask, and how to do put HEPA filters and exhaust fans, and in terms of number of air exchanges in a room, so that we learned from that as well. And come June 1, the ECQ was actually lifted to a lesser or less strict quarantine or lockdown days. So our PAO Committee on Standard actually gave back to clinic advisory for our patients, for our members. And this was through infographics as well. Also, we gave them the general guidelines on going back to the clinic. So during the enhanced community quarantine, the strict lockdown, we made sure that there was really no face-to-face consults. So at that time, the PAO recommended that ophthalmologists cease face-to-face consults and treat only urgent or emergent case during that time. However, as has been mentioned, of course, as we learn more about the disease, we change or evolve the guidelines as well. So this is also the guideline for teleophthalmology. And we also had COVID-19 testing recommendations prior to elective ophthalmologic surgeries. And you can all see it here in this website. We published it in our online journal, the Philippine Journal of Ophthalmology. So we have all the guidelines here where our members can view them as well. Aside from that, we also experienced the unavailability of masks. So we actually provided our members with guidance of how to extend for the extended use and limited reuse of N95. And we actually gave them as well goggles and breath shields for their slit lamps. So this is how initially our members were seeing patients. So you can see in the left photo, really there's not direct touching of the patient. I mean, if they are going to touch the patients, they have this mechanism on how to do it. So they are actually separated from the patients by this filters and the plastic things. And then, of course, in the video on the right, you can see one of our ophthalmologists. Then this is how he looks at the patients. You have a huge breath shield on your slit lamp. And there's a machine that actually sucks the things that the patients exhale. Okay, but of course, with the evolution of there are lighter guidelines. You can see in this left photo, one of our ophthalmologists. You can see that exhaust there. So it actually filters the air, sucks out all the some of the air and circulates it better. And then you can see easing out of the PPEs. But of course, there are really, during the initial phase, no patients really could come in because of the lack of public transport. You can see here that there's about of, so once the pandemic was, the number of cases was not that much, and we knew more about the disease. So there's less PPE being used already. So this is initially how we did the surgeries, but of course now it's less than, we use less PPEs now. Another objective was to establish a network through local chapters and subspecialty society to ensure the availability of ophthalmic care in their area, to ensure continuity of professional development activities. So the Committee on Continuing Education in Ophthalmology, the subspecialty president, PAO local chapters, all collaborated to ensure that there is continuity of professional development. So initially, from the lockdown series, we now renamed this, since there was really not much of the lockdown anymore, as to rename this to Distance Learning Program. So we have collaborated with different international and local speakers to make this series. And of course, because of the pandemic, we also did not do a face-to-face. We normally do our annual meeting December, but because of the pandemic, everything was shut down, and it has drastically changed our way of life. But we had to move on, and we had to continue our education. So this was the first Philippine Academy of Ophthalmology virtual meeting. So we held it last year. We had lectures on demand as well as live lectures. Additionally, we also had virtual exhibit halls. So this is our virtual library and our virtual exhibit halls. So of course, this is through the efforts of the Committee on Continuing Education in Ophthalmology. Particularly, the head is our Vice President, Dr. Donna Santiago, and of course, the honorary chair is our President, Dr. Margarita Latluna. So we also had our mid-year meeting, and we invited these international speakers. And the good thing about having a virtual meeting is that you can invite anyone from anywhere. So we had this distinguished panel of speakers for our mid-year meeting. And one very important thing during that virtual meeting is we presented an updated pathway for safe and effective cataract care in the COVID-19 era based on the best available evidence. And this was given by the head of our Committee on Standards, Dr. John King. So again, this was the mainstay for cataract service, include the precautionary measures, social distancing, and etc. Okay, and then, so we also are going to have our virtual annual meeting come December. So aside from this, we wanted to ensure proper referral or for face-to-face consult with patients needing urgent care and public awareness campaign regarding COVID and other related issues. So the guidelines are evolving as we learn more about the COVID-19 virus, its transmission and treatment. Practice in ophthalmology likewise evolves in the new normal setting. It's important that we keep abreast of the new developments, and the virtual or blended meetings may be the more reasonable venue for gatherings, but it allows more global participation. So thank you for your attention. Dr. Paisan?
Thanks very much, Jessica. So it seems that the Philippines lift up lockdown since June 1st. Is that correct?
Well, it has several types of lockdown. We have ECQ. Yes.
I see.
So, but we've been in lockdown for a long period of time. It's just a different level of lockdown. The ECQ is the strictest, which is it's a total lockdown. But currently we are in GCQ, or it's general community quarantine. But we are able to do our clinics now.
I see. So that's good. So it seems that the Philippines have kind of different approach to the pandemic. I think you stressed to, communication with patients and communication among doctors as well.
Colleagues.
So that's kind of unique approach for the pandemic. Thanks very much. So let's just move on to the last speaker. She's from Thailand. Well, may I ask Dr. Pimkwan, Jaruampornpan from Thailand? She's going to speak about experience from Thailand side. You please. Thank you.
Thank you, Dr. Paisan. And good afternoon, everyone. My name is Pimkwan Jaruampornpan. I'm currently a faculty at the Department of Ophthalmology, Sirat Hospital, Mahidol University in Bangkok, Thailand. And it is my honor to be representing Thailand at the AOS meeting today. And thank you, the organizing committee, for this opportunity. I'll be sharing with you about the COVID-19 situation in Thailand with a focus on how the ophthalmology practice has been affected. Just to give you a little background, Thailand has the current population of 69 million and about 10 million live in Bangkok, the capital city. We had the first reported case of COVID-19 on January 13th of last year. And we were actually the first country outside of China to detect the case. So far, we experienced a total of 3 major COVID-19 outbreaks. The first outbreak was in early March of last year, which started from a cluster at the boxing stadium with a daily confirmed cases in double digits number. The outbreak was well controlled after a month of a strict national lockdown. The issues that we faced during that first wave was the shortage of PPEs, face masks, and COVID-19 testing, similar to other countries. Our second outbreak started among the immigrant workers in the suburban province near Bangkok earlier this year, which became under control after a partial lockdown. And our third, or the current wave, actually started at a pub in an entertainment area of Bangkok around March. This is probably the largest outbreak so far, with an average daily new cases of 3,000 and about 30 daily deaths. However, we've been doing relatively well compared to the global communities, with about 1,555 total deaths since the start of the pandemic. And now our vaccination efforts have been underway since April, with approximately 7 million already vaccinated as of yesterday. So in terms of the medical practice during the outbreaks, Thai public hospitals share similar policies. Every physician wears surgical masks with or without eye protection, such as the face shields or goggles. This is the photo of me wearing the surgical mask and face shield as a routine practice in our hospital now. Most non-urgent surgeries and OPD cases were postponed during each outbreak, and all the patients are screened for COVID-19 prior to a surgery or an inpatient admission, about 24 to 48 hours prior. As for the ophthalmology practice in particular, the Royal College of Ophthalmologists of Thailand, or the RCOP, published guidelines based on the American Academy of Ophthalmology's recommendations, and which was adjusted to the Thai practice context, which I will further discuss in the next slides. So here are the guidelines for Thai ophthalmologists by the RCOP, which were adjusted from AAO recommendations and fit to the Thai practice context. It came out about last year on March 31st, and we're going to discuss each guideline in detail. First, the slit lamp barrier is recommended. So, most practices will use these barriers, which are made from acrylic, as shown in the photo, kind of similar to the Philippines, but a little probably smaller. This is pretty inexpensive, about $2 to $3 only. And however, even with this barrier, we still wear eye protections like face shields or eye goggles during the eye examination. Secondly, they recommend to avoid using the air pop tonometer during the pandemic due to the risk of aerosolized viral particles. Just to give you a little bit background, most of the ophthalmology practice in Thailand will use the air pop tonometer to screen for the IOPs for every patient in general. So during the pandemic, we try to avoid using this machine, and the recommended IOP measurement is actually with the tono pen. However, if it is needed to be used, the RCOP did provide a guideline to keep the machine in a well-ventilated area and exclude the patients who had history of conjunctivitis or history of close contact with COVID-19 cases. And after each use, we use the alcohol to wipe down the surfaces and wait for about 3 minutes between each cases to let the aerosolized particles or whatever to disperse out. The third guideline was to avoid using the immersion A-scan biometry. Of course, the same issue with the risk of viral spreading from the direct contact, and they recommend using the non-contact method instead. However, if it is needed to be used, you can clean the tip with 70% alcohol before and after use. And the fourth guideline was to maintain the physical distancing, at least 1 meter between each patient in the waiting area, and about 1 meter at least between patient and the doctor in the examination room. And any patient who has a close contact of confirmed COVID-19 cases, or those with several comorbidities who may be having a complication from COVID infection, should postpone their appointments to later dates if possible. So an electronic survey was sent out last year by a team at our institution led by Dr. Pitipon Chupong to the ophthalmologists from all over the country to explore their awareness of the guidelines provided by the RCOP and the nature of the practice that may have changed after the COVID-19 outbreak. So this was done after the first outbreak last year. So it's been about a year now. And about 15% of Thai ophthalmologists responded, and majority of them actually work in Bangkok area, which our capital city. This is just the distribution of the ophthalmologists who responded to the survey. And 90% of the survey respondents reported awareness of the COVID-19 guideline by the RCOP. So they did a good job publicizing the guidelines. And 99% of them actually use the slit lamp barrier, so very impressive number. And almost all the hospitals have physical distancing measure. As for air pop tonometry, about 75% have suspended the use, but in about 25% of the practice still continue to use, but hopefully with adhering to the guideline that by the RCOP as well. So with regards to the slit lamp cleaning, about 83% clean the slit lamp after each patient. 17% disinfect the slit lamp after 2 to 3 patients, and a few only do after a conjunctivitis patient visited. For hand washing, about half wash their hands after every patient, and the other half wash their hands after a physical contact with a patient. So in terms of other challenges that were faced during the pandemic, because the ophthalmology training for residents and fellows, kind of rely on the number of cases they were exposed to. With the pandemic, there were lower numbers of ORs and OPD exposure, and definitely, some of them graduated with lower numbers of surgical cases compared to their peers in prior years. And there are more online learning and studying for them compared to previously. And there are also additional responsibilities for them, like, most of them will have to share some of their time to go to ARI or the acute respiratory infection clinics to screen for COVID-19 patients before surgery, something like that. And also, we also have international residents from Bhutan who had to return home for several months during the pandemic to help at their home. So the other issues or the challenge that we faced was also in terms of service, the delayed diagnosis, treatments, and surgeries for our eye patients. It is definitely more difficult to refer cases from one hospital to another. And our clinical staffs, like the nurses, the assistants, were redistributed to help serve in the needed area, which is like, in COVID-19 screening or vaccination. And some of the departments have alternating working staffs, like, one team work from home and the other team, come in, and vice versa, like switching every week, for example. So there are more limited number of staffs to provide the usual service to begin with. As mentioned before, telemedicine is one of the things that got implemented during this pandemic time. Some institutions did try to use, like including my institution, try to use the telemedicine, and it's more successful in other departments like internal medicine departments. But for our departments of ophthalmology, the use is pretty limited due to the fact that we can't really do a close eye exam at the patient through the telemedicine method. So in conclusions, Thailand is recently hit with a third outbreak of COVID-19, and the hospitals are reaching its capacity limit for the COVID-19 cases. However, the vaccination efforts are underway, and hopefully, our numbers will be getting better soon. The hospitals are slowly resuming the care for non-COVID-19 patients, including the eye patients. For example, currently my hospital are at 75% capacity for the non-COVID-19 patients currently. And the guidelines regarding the COVID-19 preventions, as suggested by our COP, are being followed by most of the ophthalmologists across the country. So thank you so much, the RCOP and Dr. Pitipon and Dr. Parin for their help in preparing these slides. And this is just the photo of our Department of Ophthalmology during their the last group of residents who just graduated in the face of pandemic. You can see everyone wearing face masks.
Yeah, thank you. Yeah, so there's a new normal now, right? For the whole world.
Right.
Yeah, thank you so much, Dr. Pimkwan. Well, since we're
Thank you.
running a little bit over time here, may I ask you maybe the last question, which can be the last question for each of the speaker. So what is the lesson that we would like to share during this pandemic? May I start with the Pimkwan and then we move on to other speakers. Dr. Pimkwan,
I think,
please.
you know, the lesson learned from this pandemic, I think in general is that, you know, how the society has changed, you know, in terms of how we communicate. Now people work from home more often and, you know, we learn online more. There are so many options currently that we probably didn't realize or didn't implement before the pandemic that just open up a lot of opportunities. But also there's, you know, disadvantages of the pandemics that we are still trying to solve, like, you know, how do we take better care of the patient in limited time of limited resources time. So I think that's still something we still figuring out currently.
Thank you. How about the Philippines, Dr. Jessica? What's your lesson learned?
Yes. Well, for us now we know a little bit more about COVID-19 virus, but there's still much to learn. So that's one thing we still learn. Second, we shouldn't keep our guards down. As you know, with all this surge that are happening, we just recently had another surge 2 months ago. So we shouldn't really keep our guards down, and we just keep the social distancing, the face shield and face mask, and we should keep abreast of all the things that are developing and make sure that our guidelines are within. It's still in evolution, so that's we have to always keep updating our guidelines as well. So that's it.
Thank you. How about Malaysia, Dr. Muiz?
I think from our perspective is I think we need to educate our patients a bit more. Sometimes I just remember the patients that like for example, there were glaucoma patients who I didn't really tell them like, look, you must come and see me in 2 months, no matter what, just because your IOP is not good and things like that. Don't worry too much. I mean, not to say they need to be worried about the pandemic, but sometimes they just don't come because they think that it's okay, they got no issues. So we lost a few eyes lah. I mean, such a pity lah. I think maybe they should. I mean, when it was a bit lighter, they could have come and things like that. But yeah, I think patient education with regards to their disease, they should know what their disease is about. They shouldn't stop their medicines and things like that. I think that's from my side.
I see. How about you, Dr. Rina? You're the first, but you're the last here.
Yeah, I think all the speakers has represent what I want to say, Dr. Paisan. But I think during this pandemic, we face many hardship, but I think we can come out with many ways in educating, communicating, and we learn a lot. And I learned that there's no 100% true or certain, because then it will change in a couple of days. So I think we need to open our minds and collaborate and communicate with many people, because it's opening up to many good things beyond this hardship, I think.
I see.
If we collaborate together, as like in this meeting, it's really a good meeting. Thank you for pulling this meeting up. Yeah.
Thank you. Well, that's an experience from each of the ASEAN countries that we can invite to this symposium. But what we don't know for sure is how this is going to end in each country. Probably we need another session of how it's going to end in the future. I'd like to thank you so much, all the speakers who give the wonderful talks today. Yeah.
Dr. Paisan, I think we can have another discussion among all ASEAN one of these days, from AOS, like we used to have in the past, but we can be more COVID. For example, I really like to see the guidelines from each country, which some things which we can share, we can use, rather than having to come up from scratch. For some countries who don't have it.
Yeah. I think that's a great idea. So I think we will have maybe council meeting of the AOS council members, and I think we agree already that this year the AOS Congress is going to be a virtual meeting, probably at the end of this year, and next year we're gonna have a live meeting in Manila at the end of next year, hopefully. Well, I would like to thank you once again, all the speakers, for all the wonderful talks. Yeah, well, we have so much to learn, and this is a new disease, and it's new to everybody. So we just keep learning, as Dr. Rina said. So thank you all. We'd like to call this session in.
Thank you very much.
Stay safe, everyone.
Safe.
Good evening.
Stay safe.
Stay safe,
Thank you.
everyone.
Good evening.
Thank you.
Thank you all so much.